So hi everyone. So this is the third video of the video lecture series on contemporary implant dentistry, and in this chapter we will be discussing on the available bone and the dental treatment options. So how the available bone would impact your treatment plan. So this chapter is quite important, and I have divided this chapter again into two sections. So in the first section, we will basically talk about various classifications, bone loss patterns, height of bone, width of bone, mesodistal diameter, crown height space, and angulation of bone. So we'll see how each of these factors would impact your treatment planning, and in the next part we will use this particular classification to see how each type of bone would indicate a different treatment planning. So we'll start with this first video. So the literature reviews, basically it talks about various studies which were conducted before, and things they observed in it. So what we see is posterior mandible. The resorption is 4 times more than the maxilla. There are dramatic changes in the anterior maxilla after the tooth loss. Posterior maxilla loses bone at the highest rate. Lingual, initially after tooth loss, there is more lingual and palatal resorption, both in case of maxilla and mandible. But in the later stages, what we see is the resorption in maxilla, it shifts to the midline, and in mandible, the resorption pattern is more facial. So these are various studies which were conducted before, and they come up with various observations. All right. So they postulated so many classifications of residual ridge, but out of all those classification, what's more important for us is the Mish and Judy classification. So basically, they classified the residual bone into A to D classification, and later they added some sub classification. So we will see their classification. So this is the Mish and Judy classification. So see over here we have A, B, BW, CW, CH, and D. So type A is the most favorable type of bone. You have sufficient height, you have sufficient width, the angulation is in favor, the quality of the bone is good. However, we are not talking about the quality, and that is an entirely different classification. You must have heard about D1, D2, D3, D4 classification. So that is based on the bone density. This classification is based on the available bone height and your width. So when we talk about type B, it is again divided into two parts. The first one is you have sufficient bone in terms of width and height, but it is slightly poorer than the type A. You might have to do certain some sort of osteoplasty to improve the bone. BW is again a sub classification where you have good height, but the width is very less, and it might indicate for certain regenerative or augmentation procedure. Type C, again it is divided into C width and C height. In C width, you don't have enough width to place an implant, and in C height you don't have enough height to place an implant. D, you neither have height nor you have sufficient width to place the implant. Now, we see that the importance of bone is related to placement of implants. So, how the implant size would actually matter, and how the size would dictate the prognosis of a particular treatment. So, when we talk about size, it's basically the diameter of the implant and the height of the implant. So, implant width. So, we all know the implants, they come in different diameters: 3.5, 4.5, 6 millimeter. So, width is the how wide a particular implant is in diameter. So, why the width of implant is important? Because we see that with greater surface area of implant, the bone contact is improved, and if the bone contact is improved, there is less stress on the prosthesis. So, more surface area is equal to less stress. Standard 11 physics, we all know that stress is equal to force per unit area. So if we increase the area, the force on the implant or the prosthesis would decrease. So it's always recommended that you use a wider implant wherever it is possible, considering the bone width. So with each 1 millimeter of 1 millimeter greater implant, the total surface area would increase by 20 to 30%, which is a huge number. Okay, now there's one thing I would again want to discuss. This implant diameter with various system, the diameter could vary. So, for example, this particular company, Biocare, Noble Biocare. So, in Noble Biocare, the diameter at the crest module is slightly more than the actual diameter. So, you need to know that what brand implant you are using, and how they have categorize their diameter. So a 3.75 millimeter diameter of Noble Biocare would actually have a 4.1 millimeter crest module. The diameter at crest would be 4.1 millimeter. So you need to know, and then you plan your case. So now we come to implant height. So why height is important? Uh, every 3 millimeter longer implant provides a 20 to 30% increase in the surface area. But then again, I would say that very long implants, especially in case of two-piece implants, I'm not talking about zygomatic and basal implants, they have a different philosophy and principle. But in case of two-piece implants, increasing the height significantly won't impact the way it would impact when you increase the width of the implant. So the height of the implant or the length of the implant is of not that great value when we talk about osseointegration. However, longer implants does have an advantage of increased primary stability. But when we talk about the secondary stability or the biological stability, longer implants doesn't have that great advantage as compared to wider implants. Why? I would again tell you, because the maximum stress, it lies in the first 0 to 7 millimeter, and all those prosthetic failures or the implant fractures happens in the 0 to 7 millimeter. So typically 11.5 millimeter, 10 millimeter implant, it would suffice in most of the cases, and you don't need a longer implant unless you are planning for an immediate loading or immediate placement. So in such cases you get primary stability, but otherwise not of great significance. Further, longer implants, they do have an advantage in case of poor density bone. So if the bone density is poor, you might get some advantage with longer implants. So now we come to the measurement of the available bone. So measurement of the available bone, what all do we measure? As we already spoke. So we measure the height, the width, the angulation, the crown height space, and what are we left with? Mesiodistal space. So let's look each of these criteria one by one, and then we see how the treatment plan varies accordingly. So historically, what we see that whatever the original available bone was there, that was the guiding factor. If the bone wasn't sufficient, probably that would contraindicate the implant. But now with advancement in technology, there are more predictive regenerative procedures that ensures fairly good prognosis in terms of bone augmentation. Again, one thing that I would want to talk about is, uh, see, with advancement in technology, we are able to regenerate bone in a more predictable way. But I personally feel that as we are advancing, we are developing this habit of not sticking to the standard protocols, often violating it. I myself do it, and since I have been getting results, so that has become some sort of routine practice now to violate these basic rules. So it's a request that once you start practicing, try to stick to the basic rules, basic principles, as long as you can. There are cases where you have to deviate. We will talk about in the later sections. So, available bone height. So, you asked for a CBCT, and then how do we measure it? So, basically, the height of the available bone is measured from the crest of the edentulous ridge to the opposing landmark. So, this opposing landmark could be any vital structure or inferior border in case of mandible, or in case of maxilla it could be the nasal floor or maxillary sinus. Okay, so how does available bone height matters? So for that, we will discuss it in bit more detail, and I will show you why implantology needs multi-dimensional approach. You need to consider a lot of factors before planning a case, and there are multiple ways to overcome complications or limitations. So this particular thing, it makes implantology a vast discipline, and at the same time you definitely need real skills and knowledge to do it. With 2 days or 3 days course, it's not going to come. So imagine a scenario. We have in the posterior maxilla, this is the crestal bone, and you have the maxillary sinus over here. So the available bone over here is 8 millimeter. Now we take opposing 2. So over here we have the crown height space of around 12 millimeter. Now we all have read about this thing called crown to root ratio. So it should be less or equal to 1. Suppose we are placing an 8 millimeter implant. 8 millimeter, suppose if we stick to the anatomical restriction, then we would be placing a 6 millimeter implant over here, because we have to stay away 2 millimeter away from the anatomical landmark. So we are placing a 6 millimeter length implant, and we will be restoring it with a 12 millimeter length crown. So imagine the crown root ratio, it would become 2, which is highly unfavorable. So what are we going to do over here? So we have multiple options over here. Either we augment the sinus. Alright, we can augment the sinus, place a longer implant, and get the desired crown root ratio. Or what we can do, we can reduce this crown height space by vertical augmentation. Again, this thing needs lots of skills and knowledge. So there's another way we can do it. Why I'm saying maxillary sinus, in some certain cases maxillary sinus elevation is contraindicated, and you might end up with some complication which you don't want to handle. So there are multiple alternate ways to do it. So this is your vertical augmentation. So suppose you don't have that skills or knowledge to do the vertical augmentation, what else we can do? We can place more number of implants. Instead of one, we can place 2 implants, provided we have width and sufficient mesiodistal space. All right. So we see that in a particular case, how extensively we need to plan. How many things are there that we need to consider. So this is just the local consideration. There are other factors, systemic health conditions, what all you need to consider. So that's what I'm saying, that develop this habit of reading textbook, and that's why we have come up with this particular video lecture series. So available bone width. So when we talk about width, basically what is ideal, I'll say, suppose this is 4 millimeter diameter implant. So generally you would need around 2 millimeter of buccal bone, and around 1 millimeter of palatal or lingual bone. Okay, again I would say that I myself violate these principle, and there are cases that even if there is just even if there is 1 millimeter of facial bone, I would happily place my implant, and if the complication arises, then I would do augmentation or regenerative procedures. But we have been doing these violations. Okay, so when we talk about width, so this is the standard protocol: 2 millimeter in the facial aspect and 1 millimeter in the palatal or a lingual aspect. Available bone length, that is the mesiodistal dimension. All right, so suppose you have a tooth over here. there is an edentulous space and you have one more tooth over here. So we have to place an implant in this edentulous side. So how do we plan? See, if it is a tooth, you need 1.5 millimeter of distance from the adjacent tooth. Okay, had it been an implant, if this was an implant, you would need 3 millimeter of clearance, minimum 3 millimeter of distance between two implants, and between tooth and implant it should be 1.5 millimeter. Okay, so what you do is, this is your tooth, this is your another tooth. So you take a measurement of 1.5 millimeter, suppose this is the 1.5 millimeter, and start drilling over here. Correct? That's how we do it. Completely wrong. So when we talk about 1.5 millimeter of clearance, in order to get the 1.5 millimeter clearance, we would need to add the radius of implant. So when you are doing the initial ditch, you would take 1.5 millimeter plus radius of implant. So suppose your implant is 2 millimeter, 4 millimeter in diameter, you would take 2 millimeter plus 1.5 millimeter. So your initial ditch would be at 3.5 mm. Again, these calculations would vary from case to case. Suppose this tooth was inclined mesially, you would need little bit more clearance. Okay, one more thing, if you are placing an implant adjacent to another implant but that implant is restored, you need to consider it as a tooth, and the distance, then again clearance would be 1.5 millimeter. So if an implant is restored, don't take 3 millimeter clearance, you need to take 1.5 millimeter of clearance. All right, from now the question arises from where you want to get this clearance. So I have to draw this properly. So this is the interproximal contact area, this is the CJ, and this is the tooth and crestal bone interface. So all your calculations should be from tooth and crestal bone interface. Alright, so again there's one more thing that you need to consider. Suppose this tooth has some sort of horizontal defect. So in that case, your calculation should be 2 millimeter below the CJ. From there you need to calculate. Alright. Now it's available bone angulation. So we see that the angulation is actually perpendicular to the plane of occlusion, except in case of maxillary anterior, where there is slight angulation. And this angulation, they follow the Wilson and curve of Spee. Again, a prosthodontic thing, conventional prosthodontic thing. So you need to stick to the basic principles. If you are good with the basic prosthodontics, if you are good with basic surgery, implantology won't be a difficult thing for you. Okay. So same thing is given over here in the maxillary anterior region. There is some sort of angulation and it is not perpendicular to the occlusal surface. So in such cases, you have to be very careful while planning the implant. So we will discuss about it when we talk about the ideal implant position chapter. Okay, divisions of the available bone, division A, division B, C, CW, CH, we will discuss in our next lecture series. So that's all for today's lecture. I hope you understood it, and watch it twice or thrice. You will get this clearly. If you have any doubts, write us in the comment section. Thank you.